Our research is focusing on identifying new familial melanoma genes. So these are genes or mutations that are high penetrance that occur in melanoma families with large numbers of cases. So we've been sequencing using exome or genome sequencing multiple members of families with 4, 5 or even more cases of melanoma and looking for some common extremely rare variant that is segregating with melanoma in those families. So we actually have found quite a few variants that do segregate, but the hard part is actually working out which ones of these are actually the smoking guns. And so we started by looking at the ones that are clear loss of function mutations. So these are mutations that cause a premature truncation of the gene products. And we've found a number of those in the DNA repair pathway that intuitively make good candidates for melanoma predisposition genes. We have not looked at organoids yet, and one of the issues with melanoma is that it's actually not an epithelial cancer, and organoids work really well for epithelial cancers, but melanocytes in the normal skin actually are dispersed, so they don't actually sit adjacent to each other. There's a lot of cells in between, so they don't actually meet, I guess, the criteria for easily forming an organoid. But they could be, an organoid could be made, of course, if they were co-cultured with keratinocytes, for example. And so this is something that I guess could be done in the future, but it's not an area of research that we're actually investigating at this point. Yeah, so I think the issue with some of these familial melanoma genes is their applicability to therapy. They have a clinical utility up front in that you know, once they've been proven and they're robust findings, then they can be going straight into genetic counseling, clinical genetics applications where people can be screened and given counseling depending on what their mutation status is. And those people can also then have more rigorous surveillance. They can actually have whole body scans for nevus or melanoma development on a regular basis. But depending on the actual gene product, it's an open question of whether or not targeted therapies can be useful. If we look at the genes that are already known familial melanoma genes, then those in the CDKN2A, CDK4 axis clearly do have a therapeutic angle in that they signal to the cell cycle, and there are now a number of CDK4 inhibitors actively in clinical trials. And so at least in those patients that carry germline mutations of CDKN2A, CDK4, you would expect that those kind of inhibitors would actually prove to be quite useful. But for a number of the other genes, there's no obvious target at this early point in time. I think one important thing for people to think about is that whilst about half of all the high-density familial melanoma families are yet to be explained in terms of their genetic risk at this point in time, it is possible that while some very rare sort of even private mutations do account for predisposition in a number of those families, it is also possible that a number of the other families have, if you like, multiple melanoma cases by other means, either shared environmental factors or shared genetics at the polygenic level, so many genes acting together. So what I'm thinking of then is a number of people in families could all have the sun-sensitive skin type, so they could be pale, they could have red hair, freckles, they could not tan very easily. And in mixing that with shared environmental risks, such that the families all go to the beach together and decide not to use sunscreens, could be a reason why you get this clustering of cases in some families. So it's not purely an autosomal dominant single gene mutation that accounts for them.